So everybody, thank you so much for joining us this morning. We have somebody who is very, I think, near and dear to us here in San Diego, Don Blaskiewicz, who has a really interesting and timely topic, the impact of patient-specific implants. So really thrilled to have Don join us and to share what he's learned about that, and hopefully to leave the fellows with just a couple of pearls that they can take away into their practices. So Don, without further ado, I'm going to turn the reins over to you if you want to share your screen.
Thank you. Okay, so I got to go into presenter mode. Amber walked me through this the other day. All right, can you guys see that?
Not yet. I don't think, at least I don't see it.
All right, let me do this. Maybe I got to go here.
You hit the share screen tab.
There we go. Here we go. Share. And then I'm going to go to presenter mode. Better?
You're all set, man.
You got it.
Let me minimize this. All right. Thanks everybody for being here. This is, just a great opportunity to present to the fellows some of the emerging technologies. Let me see, I got to press here to go. Currently, here's my disclosure. Some of them kind of are relevant today because I do consulting work for both Medtronic and Carlsmed, both of which products I'll be discussing today. As we know, emerging technologies have been huge kind of in all of our practices as we continue to evolve as spine surgeons. And clearly patient-specific implant space has grown over the past number of years, both in the orthopedic and spine world. And today I'm going to discuss in particular the Metacardia unit rods, which is now under the Medtronic flag, and also the Aprevo patient-specific implants by Carlsmed. I'm going to go over the rationale for patient-specific implants and discuss the impact of AI and machine learning on patient outcomes and give a few case examples. So if you haven't seen this yet, the Adaptive Spine Intelligence program through UNID is really nice. It allows you to kind of upload images, and either via your desktop, laptop, or phone, you can directly interact with the biomechanical engineers to simulate plans, come up with a plan, approve a plan, and then have implants made. So it's really easy, and it's great to pull up the plan on your phone in the OR just to take a peek at things. So why does all this matter? We know that radiographic parameters are so relevant and are continuously evolving. If we go a number of years back with sort of the evolution of the SRS Schwab criteria, then moving on to sort of the age-adjusted criteria, looking at how the spine changes as the population gets older, and then looking at the Rousseli classification, where there's definitely not, rigid goals, but more or less looking at the association of what pelvic incidence does to lumbar lordosis and thoracic kyphosis, and then putting people into stratified groups and kind of using that as a template of where we need to move people. And then also looking at sort of like the GAP score, which utilizes pelvic tilt, lumbar lordosis distribution, global tilt, ultimately to give a recommended lumbar lordosis to get the patient proportions. And now kind of looking at things like target lumbar lordosis and target L1 pelvic angle. So what are the clinical benefits of sagittal alignment? We know that sagittal alignment is the most dominant radiographic predictor in patient outcomes that we have. And we know that if you look at patients undergoing standard surgery versus those with UNID, you're much more likely to achieve alignment with UNID rods versus without. And this is a problem that's been endemic to us as deformity surgeons. In this study, Branch et al. Looked at the curve radius of patient-specific UNID rods relative to standard rods. And what they noticed is that the rods that were made through UNID were highly personalized with standard deviations of 40 to 53% from average curves in the pre-bent rods that we get. And this was especially true for constructs in the lumbosacral and cervical regions. And kind of what we learned from that is not one size fits all, as with the standard rods that come in most of our vendor trays. So machine learning through databasing can help us predict thoracic kyphosis. So Lee et al. Analyzed 20 adult deformity cases instrumented from T10 or T11 to the pelvis to determine the ability of the unit adaptive spine intelligence software to predict postoperative pelvic tilt and thoracic kyphosis in uninstrumented regions of the spine. And so what they were able to determine is that using sort of the machine learning algorithms, they were able to predict with a very close p-value the thoracic kyphosis, the uninstrumented thoracic kyphosis, and the pelvic tilt. And this, what this drives at is that this may be useful for us as surgeons to help prevent proximal junctional kyphosis in these thoracolumbar fusions. Also, we think about the incidence of rod fracture rates, and it's about 9% in the historic ISSG database. And those patients undergoing PSO, it's about 22%. And in this study, looking at the comparison between unit-specific rod data compared to the known database, in standard deformities, there's only a 2.2% rod fracture rate, and in the PSO, there's only a 4.7, so a huge reduction in the known rod fracture rates. And we do know that when given a template, surgeons are able to more accurately bend rods. So in this study by Sardi et al., 10 experienced surgeons were asked to contour rods using a French bender to 40, 60, and 80 degrees. Without the templates, the surgeons overbent by a mean of 7.5 to 20.2 degrees for each desired angle. But with a template, they came within the average of 2 degrees of their target. So how does this all work? So, the unit system, it's a concierge service with biomedical engineers to simulate surgical strategy. AI-powered models estimate the postoperative spinal compensation, and using predictive analytics, patient-specific implants are customized to the surgical case plan. So with predictive modeling in adults, you will have a case and we'll get preoperative images, full-length standing pictures. And then what we'll do in the planning phase is we'll obtain key spinopelvic parameters and also biometric data such as age, gender, height, and weight, and using predictive modeling in the adaptive machine learning, we'll come up with plans to understand where the thoracic spine is going to compensate and also what's going to happen with pelvic tilt. And so this is also true in the degenerative cases, leveraging the AI and machine learning to drive a new degenerative algorithm that predicts key compensatory mechanisms in the lumbar spine 6 months postoperatively. And this will predict changes in lumbar lordosis in the upper non-instrumented levels, changes in pelvic tilt, changes in sacral slope, and it requires just regional x-rays showing, L1 in the femoral heads and any lumbar fusion that includes a sacrum. So this is really the wheel of life of how this works. And it starts out with imaging analysis. So we all get our standing x-rays, we get our supine x-rays, bending x-rays, coronal bending x-rays, CTs, MRIs, all the usual. But the key images are uploaded into the software, and then case simulations will take place. And so I'm going to put this up here because this is a case that I have upcoming. It's a gentleman with an L1 collapse, and he's hyperkyphotic focally. And so 3 different plans will be generated based on, probabilities. And what I can do is look at this and determine, do I want to attempt this through a bunch of low-level osteotomies, a PSO, or a VCR, and the numbers will come up here. And so, it gives you a few different options. And so once you come up with a plan, patient-specific implants will be made. And at this point, there's over 6,000 surgeries performed and about 200 surgeries a month that are using the unit technology. And you can come up with transition rods 5560 in both titanium and cobalt chrome, MIS and tapered. And the industrial smoothing process gives you a non-notched rod. So it's like perfectly bent. And I also use this intraoperatively as a template. So as I'm doing my surgeries, I'll frequently, ask for the unit rod. I'll put it into the patient. I'll see where things are, how things are lining up. Do I need to do more releases and so forth? So it's a great intraoperative template. Afterwards, we upload the data back into the unit database. And through machine learning and algorithms, predictive modeling for upcoming cases is performed. And this goes into the greater database. So when other people submit cases and they have similar spinal morphologies, it will use that in the predictive modeling. And then afterwards, you can do a post hoc analysis of your cases and understand how you're doing compared to the last case, to where the patient needed to be and how others are doing in the database. And this was a recent meeting on a case that I had done. And if we look at the slide on the left here, this is, the red line here is where the patient was pre-op. This was the plan, and the blue line is the unit template. And here's the pre versus post-op, and here's the plan versus post-op. So if we look at the green line, that's where the patient wound up. And if we look at the blue line, that was the unit rod. So, I'll present this case in just a moment, but it was a pretty significant curve. And to get him within literally like a few degrees of the plan was amazing. I'm going to skip through some of these. And I'm going to do this unit case presentation. This was another case I did recently. So this is a 64-year-old female who years ago had a gill procedure 4-to-1. She underwent an L2 to attempted L4 posterior spinal fusion in 2014. She has a variety of medical issues, but no red flags. And then on her medication history, she's on an enormous amount of morphine milliequivalents a day, of almost up to 480, given her spinal deformity, which I'll present in a minute. So in 2016, this is where she was. In 2017, an outside provider did a T3 to the pelvis on her. She had immediate proximal junctional failure with a UIV +2 of 24.5 degrees and a T1 slope at 51 degrees, and no further actions were taking. So she kind of dwindled over the next few years. And you can see from 2020 to 2021 to September of 2021, she progressed with a 56-degree focal kyphosis and a 64-degree T1 slope. She ended up having prominent instrumentation, which eroded through her skin. She was seen by an outside neurosurgeon, plastic surgery, and ID. She underwent removal of the failed instrumentation at T3, T4, and placed on antibiotics. And she was referred to me at UCSD about a year and a half ago, at which point she was still undergoing sort of her protracted course of antibiotics to clear up her deep infection. And then finally, when I saw her, she had worsening myelopathy, increased incidence of falls. Her previous incision was well healed. Her ESR and CRP had normalized. She was cleared by ID for surgery, and her A1C was well controlled. So this was what I was kind of looking at going into surgery. And I did my own planning on SurgiMap, as we all tend to do, coming up with different corrective strategies for her, but not really knowing where I need to get her. And then putting this imaging into the unit database and going through sort of the predictive analytics and algorithm, coming up with sort of a very well-defined plan to get her where she needs to be. And moreover, for me, the strategy, just like a pilot in an airplane, I had a flight plan. I knew I needed to do a T3 VCR with a 0-degree angle and an anterior height of 27 millimeters, such that I'm growing the anterior column and not just compressing posteriorly and kinking the cord and all those other untoward things that none of us like. So I had her as a stage surgery. I went and explored the incision. I obtained cultures. I removed the posterior instrumentation. I did a gram stain on her, which was negative. Let cultures come back for a few days to make sure there wasn't some degree of indolent infection. And at that time, I just did low-grade osteotomies to kind of loosen her up, and I placed temporary rods. Stage 2 of the surgery, I had planned for bivector traction, deep irrigation, a T3 VCR with the anterior height of 27 millimeters, and to use an expanded expandable cage, grow that anterior column, and then detach the VCR site from the unit template. And so this was her in the operating room. Chest pad was placed down here, shoulder rolls here, bivector traction here. Opened her up. I did the VCR, rib resection, so forth. And then the amazing thing is the unit rod kind of fell right into place. And I mean, you know, if you've done like these upper thoracic VCRs, they're very challenging cases to get patients aligned. And it's often you go through a lot of troubleshooting maneuvers to try to get things, you know, approximately where you want them. But as the unit rod, it was a guardrail showing me exactly where I needed to have the patient. And it was amazing to me that she kind of fell right into place. And here she was afterwards. So she avoided an ICU admission. Her morphine mill equivalence was reduced from 240 to less than 90. She was neurointact. She went home on post-op day 3 with her Ioban and drain, aspirin at all times except for showering meals, CTO for ambulation, and come back to clinic in 2 weeks. And here she was at her 6-week follow-up. And again, this was one of those cases when we did our, you know, post-surgical analysis. It's like, gosh, this lady fell right into where she needed to be. I want to change gears and go into Aprevo. I know a number of us in San Diego have been proponents of using this technology. And so this is sort of addressing our known post-operative complication rate of 46% and revision surgery of 26% by taking it to the interbody space. And so with standard stock implants, you know, these are mass produced in standard shapes and sizes. They don't necessarily fit the patient's anatomy as the patient needs. They're not integrated into the overall realignment plan. They offer minimal coronal correction. There's point loading of the end plates and high posterior rod stress. But with patient-specific implants, they're designed to fit sort of the end plate topography. You can build in deformity correction as we're designing these if you need to, you know, grow one side of the spine versus the other. And this is particularly useful when we're attempting to correct the fractional curves at the base of the spine. And because of the increased contact area, it optimizes the environment for fusion, reduces high stress concentration, and lowers posterior rod stress. And so these are built on demand. You again have interface with engineers, and they help you achieve your surgical correction. These are sort of state-of-the-art 3D printed with porous titanium architecture and fully personalized, again, off of a CT scan. So it's sort of like jigsaw puzzle, fitting of these implants into the space where you need them. And when we think about regular implants, there's the cage end plate interval. So if we look at these images over here on the right, you know, cages have been placed into the intervertebral space, but there's all this dead space. Number one, you know, the graft doesn't usually have contact with the end plate. The allograft or autograft doesn't have contact with the end plate because, you know, end plates aren't typically flat, or our implants are, and you know, this increases stress on the end plates. So if we look at a comparison of a stock implant versus an Aprevo implant, and we look at the heat map that's produced and stress on the end plates. So on the top here, this is the inferior end plate, and this is the superior end plate. And if you look at the heat map, you can see the point loading that takes place with a stock implant versus that with distributing the stress more evenly over the contour of the end plate. So again, this will ultimately help lessen the degree of subsidence. And so when we look at a comparison between patient-specific interbody devices and stocks for achieving planned correction and the treatment of adult spinal deformity, you know, we are dialing in coronal correction within 0.4 degrees, lordosis correction within 0.5 degrees, and posterior height within 0.2 millimeters compared to standard implants. This was a paper presented by, you know, our UCSD team at CNS just this year in Austin. And basically this was a multi-center evaluation of 39 patients with 67 Aprevo implants. And this was analyzed pre and post-operatively, the key spinal pelvic parameters in patients receiving custom interbody implants for spinal deformity. And what we discovered is that the target global and spinopelvic alignment was achieved within near range using Aprevo implants. And so how it works, this is based off of both standing X-rays and CT. So you get scans and they're uploaded into the Aprevo software. And you'll work back and forth with your software engineer to come up with a plan. What is it you want to do? How many degrees do you think you're going to need? And with their predictive analytics software, they will give you, based on various modelings, how you can get that patient to where they need to be. The 3D implants are turned around really quick, made here in the United States. And then at the time of surgery, it's a full ensuite package with inserters and so forth. So you go in and it's really lock and key. You put these things in and they just fall into place. I've done multiples of these right now and it's really amazing. Just when it's in, it is in. And so we are going to go over just a couple cases here. And again, this is this sort of virtuous iterative cycle similar to the unit, where you have a plan, you approve the plan, it's produced, you do the surgery, the data gets put back into the system. So the system is continuously learning and optimizing algorithms for future surgeries. This isn't my case, but it's a basic case looking at just a 5-1 ALIF, which is just a very common intervention that most of us do, and looking at sort of the preoperative numbers, with 4 degrees of lordosis and an anterior height of 3.8, posterior height of 2.4. And the plan with this was a lordosis of 12 degrees, S1 angle of 21 degrees, anterior height of 11.8 and a posterior height of 6.7. And here's sort of the 3D modeling based off of the CT with an implant to fit and achieve those goals. The product comes sterilely packed and you get one size up and one size down, just in case there's some anatomical limitations with getting the implant in. And here was the post-op imaging on this case. And what I want to do now is look at sort of a marriage of a unit and Carlsmed case in this very complex deformity case in a type B curve. If you look how just severely decompensated this guy is, his ribs are hanging off the side of his ilium, and his SVA is, 283 millimeters. So, this is a really challenging case. And for me, this was a great opportunity to allow the algorithms to come up with a plan for this patient, give me the templates I need, give the specific interbodies to correct the fractional curve at the bottom, and get this guy back to where I would like him to be, or where the computer tells me actually where he should be. And so I start out with a unit plan, and it will give me sort of, the key objectives where I'm going to work with the ALIFs at the various angles in the lumbar spine and where I need to do my releases. And I'll come up with a plan. And so this was the plan I approved for this gentleman. And again, it's based off of, machine learning and what is going to be, the predictive outcomes of his pelvic tilt and his cervicothoracic junction. I then take the plan and I'll move it into the Aprevo software, and we'll come up with this. And we were going to address the very lower part with patient-specific implants, and we had pretty specific goals with lordosis between L4-5 and L5-S1, anterior height and posterior height. And the implants were, mocked up on the CAD drawings and approved. And if we sort of look at, my objective to horizontalize the L4 vertebral body through growing the concave side of the spine. And then this was surgery on him. So it was sort of like one of these heroic corrections where I addressed the base with patient-specific implants. We did an L3-4 ALIF, loosened him up in the back. And again, kind of how I used the unit rod was as a template. I would keep putting it in, say, where do I need to be? What do I need to do? How do we push this over? I started out on him actually using a temporary rod on the concavity and using that to help reduce and distract on that. Then I put the permanent unit rod in on the convexity, and then swapped out the temporary rod on the concavity, straightened him out, put in the kickstand rod, pushed him over even further, and then put in this ancillary rod running medial on that side. And so he went from that to that, from that to that. And again, when we looked at, his post-op analysis from pre to plan, I mean, gosh, like if this was left to my own hand, I never, ever would have got this guy dialed in like that. And I really, attribute this to trusting the plan. I was on a user group meeting. It must have been a couple months ago now, with Larry Lanke and Chris Ames. And the one thing that kept coming up again and again was trusting the plan, believing in the software and the algorithm and the predictive analytics of where the patient needs to be. And then intraoperatively, we need to execute. All we need to do is execute whatever releases and corrective maneuvers to get the patient where they need to be. And so we're learning that, we get the patients, reduced to the rod. And yes, there's deflection. And yes, there's some inherent challenges with, derotation and some of the big coronal curves at this point. But trusting in the algorithm is giving these tremendous outcomes. And so I know we're getting close to time here. I want to leave a few minutes for questions. But, in summary, through data collection and machine learning, a continuous cycle of improvement is created. And through database enrichment, by continually pumping in pre-op and post-op patients, predictive analytics can model reciprocal changes with various treatment plans and help to mitigate untoward complications such as PJK, rod fracture, and revision rates. And patient-specific implants serve as the guardrails of successful correction. And I'm going to stop share there, and you can come back and look at my handsome face. So that's where it's at. And I know Dr. Kleck's using a unit as well in Colorado. And I don't know who else is on the call here.
Hey, Don,
we're in our user group meetings. It's just amazing. You just hear again and again, just trusting the plan and the outcomes that we're getting. It's really astounding. I mean, it's so fun to be alive at this time and be at this place in spine surgery. I think we've all been through various sort of, inflection points with amazing changes, such as with lateral surgery. And I think now patient-specific implants is really, at the forefront of all of this.
Don, thanks. That was really an awesome talk, man. And I appreciate you putting it together and sort of charging forward in this field. One question I think for the fellows, hopefully at least in the first couple of months, maybe first year, they're not going to be tackling things like, T3 VCRs and so forth, but some will certainly do some challenging deformity cases. How can they sort of start using this? What's the barrier to entry? When you're starting your practice, how do you sort of get involved with patient-specific implants? What's the right case to sort of introduce it?
I think all the cases are the right instance for it. In fact, most of our fellows that are coming out, they're going to end up being the complex guy for their group or their practice, and they're going to be sent these lumbar deformities. And as you know, like T10 of the pelvises are some of the most challenging cases, personally firsthand, as I do, because of the PJK rate. Mm-hmm. And I think using sort of the, predictive analytics and understanding what are the reciprocal changes, using software and modeling, and giving, a template of where the patient ideally should be, hopefully they're going to be able to use that as sort of a safety net to prevent some of these, challenges that the rest of us have had in our careers, not only just early on, but also mid-career and later career, right?
Totally. Do any of the fellows have any questions? I know we're coming up against the time limit. We've got a few more minutes.
Oh, David's got his hand up.
Hey guys, Don, thanks for the presentation. That was great. Obviously here in Colorado, we've been using UNID for a while. The major barrier for us has always been like the additional cost or justifying the additional cost to the hospital. Can you comment on that barrier when it comes to the Carlsmed patient-specific interbody implants?
Yeah, so there's definitely a premium, and it's the first one's pretty expensive. The second one is less. The third one is even less than that. But I think leveraging the outcomes is really where we're going to see the benefit in this. And I know when we go to our hospital value analysis committee and say, hey, we've got this new thing that we want to use, they look at the price and they say, well, how's that different than putting in a cortical bone dowel in the inner space? But I think it's really like this is outcomes driven, right? And I think, UNIT has successfully proved that, as firsthand. And I think that will also be demonstrated as more and more Carlsmed cases work their way through. Personally, I can attest to that in sort of the number of cases I've done. And I'm just very eager to keep contributing cases to the database, because that will ultimately benefit us all as surgeons and moreover benefit our patient population. Kumar had his hand up too.
He wrote a question in the chat, Don. He said, what do you think are the barriers to widespread adoption? It's somewhat, dovetail with David's question.
Yeah, I think one is cost. Number two, some people kind of get set into their practices, particularly on the DGen side, that it's just about clinical throughput. But I think, there's those of us that still have the intellectual curiosity of wanting to do better, even on the smaller scale. Like, to me, some of the most challenging surgeries are almost like 1 or 2 levels. T2 to the pelvis is pretty straightforward. I mean, you can get them pretty dialed in, but it's the small ones, as and sort of that cascade of, multiple revisions afterwards. I think anything we can do to help improve that. So keeping an open mind early on and looking at the horizon and what are sort of the thought leaders doing and promoting, it's just these are the topics that are being talked about at the meeting. So I think early on, these are the things we should be gravitating towards, not going back to the Stone Age of spine surgery.
Awesome. Well, Don, awesome talk. Obviously a very timely topic, and look forward to learning more as the iterative process, improves over the next couple of years, man. So
yeah, well, thanks everybody. It was great to be here today. Y'all have a wonderful weekend. And Handy, I'm looking forward to getting on the slopes with you this winter.
With both Achilles intact.
Yes, sir. Both of
All
mine.
right. Have a great Friday, everybody. God bless.
Bye, everybody.